In this video, what we're going to do is focus on the vascular part of the cardiovascular system. And you already know that there are three main types of blood vessels. Arteries are carrying blood away from the heart, and it doesn't matter whether the blood is high in oxygen, as in the systemic circuit, or low in oxygen, as in the pulmonary circuit. And then veins are carrying blood back towards the heart, and again, the amount of oxygen present is not important. Capillaries are leaky, and they allow for exchange of things like respiratory gases, nutrients, wastes, etc. The middle part where the blood flows is what's referred to as the lumen, and not surprisingly, there are clearly differences in the size of the lumen, and we'll see that that's true even when we compare arteries and veins serving the same area. Those arteries and veins that serve the same area or the same organ are referred to as companion vessels. Typically, we find three layers in the wall of each blood vessel, but we'll find that there are exceptions to that. What I'd like you to do is to pause the video and look at this diagram and just note as many things as you can. One of the things that you might have noted is that as arteries move away from the heart, they branch or diverge. The other thing that you should know is that as they diverge, the lumen gets smaller and smaller. On the other hand, as we come back in the veins, we have fewer and fewer in number because they converge. And again, as they converge, the diameter, the lumen, also gets larger and larger. You might also notice that there are different types of arteries. And so we have very large arteries that are also known as elastic arteries because they have a very high elastic component to them. Then we have muscular arteries, and then we have the smallest of all the arteries, the arterioles. You can also see that there are capillary sphincters leading into the capillaries. These are little bits of smooth muscle that can either contract and cut off blood flow to the capillary, or they can relax and let the capillary be perfused with blood. And then notice that veins are also referred to as capacitance vessels. We'll talk more about this later on, but it just means that they can hold a large volume of blood. Here you can see a picture of two companion vessels. And when you look at the arteriole and venule, differences are apparent to you. One of the things you notice is that the arteriole has a nice thick wall where the venule doesn't have such a thick wall. Part of the reason for this is because of the pressure on the arterial side is much, much higher than the pressure on the venule side. And so we want a nice, strong wall. The other thing you notice is that the lumen of the venule is considerably bigger, even though they are companion vessels. And as the pressure drops, it's harder for blood to flow through a tube. And so by increasing the diameter, we ensure that blood flow will continue. And so again, there you can see the difference in the size of the lumen, and you can also see the difference in the size of the wall. Another thing that we find is that veins have valves, and again, this is a consequence of the very low blood pressure. Blood pressure is so low that it is possible that blood could flow backwards in the veins, and so valves help to ensure unidirectional flow. The different layers of the blood vessels include the tunica intima. This is the inside layer, the layer closest to the blood. And the most important part of this is the endothelium, and so it's simple squamous epithelium, and it is indeed continuous with the endocardium, which is also simple squamous epithelium. And it turns out that this is very active and plays an important role in vasoconstriction, vasodilation. As we move away from the blood, we come to the middle layer, which is known as the tunica media, and it's composed mostly of smooth muscle. And as you're aware, if the smooth muscle contracts, we'll get vasoconstriction. And if the smooth muscle relaxes, we'll get vasodilation. And then lastly, we come to the outer layer, the tunica externa. It's mostly areolar connective tissue, but again, there are elastic fibers there, especially in the elastic arteries, but even in the muscular arteries and the arterioles. There's not nearly as much elastic tissue in the veins. So again, the largest of all the arteries are what are known as elastic arteries. They have a high compliance. This is important because it allows storage of elastic energy and recoil. And the recoil actually helps the heart to push blood through the system. We don't want the compliance to be too high. That would be much like a balloon that you actually can't inflate. On the other hand, if the compliance is too low, it would be kind of like a baggie or a sandwich bag. It inflates easily, but there's very little, if any, recoil to it. The arterioles are the smallest of the arteries, and the smooth muscle in the arterioles at rest is partially constricted, giving the arteriole tone. And so that arteriole can either get the smooth muscle to relax and vasodilate, or it can get it to constrict further and vasoconstrict. Changing the diameter of the arterioles has the biggest impact on what's known as total peripheral resistance. And so the arterioles are also referred to as resistance vessels. We'll talk more about resistance to blood flow in class later on. Again, the arterioles are known as resistance vessels. That's because they can vasodilate and vasoconstrict and allow us to decrease blood flow to an area or to increase blood flow to an area. And blood vessels which have a lot of alpha-1 adrenergic receptors on the smooth muscle will primarily respond by vasoconstricting. On the other hand, blood vessels that have primarily beta-2 adrenergic receptors will respond primarily by vasodilating. And so it's not surprising that we find that the arterioles of the heart and skeletal muscle are high in beta-2 adrenergic receptors, whereas the blood vessels of the internal organs are high in alpha-1 adrenergic receptors. And so when we exercise, we divert blood away from the internal organs and to the heart and the active skeletal muscles. This is also where arteriosclerosis can occur. And again, you might remember that arteriosclerosis is the buildup of fatty plaques on the inside of these arteries, making it harder and harder for blood to get through. And so if arteriosclerosis is occurring in the coronary arteries, there's a much greater chance that the person will suffer from coronary artery disease and perhaps have a heart attack. If it's in the cerebral arterioles, then they're more likely to have a stroke. This is also the primary area where we can get aneurysms. And an aneurysm is a thinning of the wall of an arteriole. And because the wall is thinner, there's a greater chance that it might balloon or pouch out in response to the high pressure that we find in the arterial system. And sometimes that ballooned out area can actually rupture, and then you get a ruptured aneurysm. One of the things that they can do to treat an aneurysm, if it's found, is to thread a catheter in with a coil that can be heated up. And as they heat that, it makes the blood in there coagulate and strengthens it. Now, while aneurysms occur primarily on arterioles, they can in fact occur on larger vessels, and they can even occur on your aorta. And so here you can see a diagram of what's referred to as an abdominal aortic aneurysm. Obviously very dangerous, and if it's not found and repaired, if that burst, there's very little likelihood that the person would survive from that. Moving on, we come to the capillaries, which again are nice and leaky. They're microscopic, so we didn't even know they existed for sure until the invention of the microscope, although there were people who had hypothesized the existence of capillaries. The walls consist of an endothelial cell sitting on a delicate basement membrane, and so nice and thin. We make it as thin as we possibly can. And then, as we already know from lab, in many, only one red blood cell at a time can move through, and these things are so narrow that sometimes we have to squeeze the red blood cell a little bit. And if you look here in this diagram, right down here at the bottom, you can actually see a red blood cell as it is coming out of that capillary. And then here you can see what's known as a rouleau, which again we talked about in lab. And so you can just see this, this row of red blood cells marching through one after the other. And again, these are the vessels which permit exchange of respiratory gases, nutrients, waste products, and so on. Not all capillaries are the same. Most capillaries are what are known as continuous capillaries. And again, they're a tube made up of endothelial cells that are joined together. However, they aren't joined together really, really tightly. We have these clefts in between the cells known as intracellular clefts, and that makes them leakier. And so other stuff which might not pass easily through the phospholipid bilayer of the endothelial cell membrane can get through those intracellular clefts. In some cases, we want capillaries to be even leakier. And so what we do is we squeeze the phospholipid bilayer together, pushing out the cytoplasm. And so right here, there's no cytoplasm. In these other endothelial cells that you see to the side, the cytoplasm is kind of salmon-colored or pinkish. In addition to that, the membrane is thinner than normal, and this creates these little windows, the black dots that you can see here, that are also known as fenestrae. And so these are fenestrated capillaries. And then in some cases, we have actually big gaping holes in the capillaries. These are referred to as sinusoidal capillaries, and they're larger in diameter. And so again, here you can see the three different types of capillaries that we have. And you might ask yourself, well, why would we have fenestrated capillaries? And so think about when you might want a capillary to be leakier. And what you might think about is, when do we need a lot of stuff to cross the capillary? So pause the video and see if you can come up with a few places where you'd expect to find fenestrated capillaries. And okay, if you said the kidney, the small intestine, the choroid plexus, endocrine glands, then you'd be absolutely right. Small intestine might be the most obvious example because that's where we're absorbing lots and lots of nutrients. But in the kidney, we're absorbing a lot of stuff, we're excreting a lot of stuff, and so there too as well. Now you might pause the video and see if you can figure out where we would have these fenestrated capillary, which are also known as open pore capillaries. And so there are places where we actually need to move whole cells across the capillary. And so places where we find sinusoidal capillaries would include your liver, red bone marrow, spleen, adrenal medulla. Here you can see a transmission electron micrograph of just a regular old continuous capillary. And there they've pointed out for you an endothelial cell junction. Doesn't look to be quite as leaky as we might expect it to be, but again, we do find these areas where the endothelial cells coming together, not being really, really tightly joined. And here's a scanning electron micrograph of a fenestrated capillary, and each little dot that you see there, that's a place where we've squeezed out the cytoplasm, and the phospholipid bilayer is actually a little bit thinner than it typically would be. And so that makes those guys even leakier. When we get to the capillaries, we have what are referred to as microcirculation. And the microcirculation includes the arteriole, as you can see here. But then you can also see that there's this tube that goes directly from the arteriole to the venule, which is known as a metarteriole. And this can serve as kind of a vascular shunt. And so there are times when the blood just goes directly from the arteriole right on through to the venule. And what we're doing is we're going to go ahead and we're going to constrict the capillary by shutting off these precapillary sphincters. And so here you can see an example of where we've done that. And so metabolism in the tissue here is relatively low. It doesn't require much O2 or much nutrient. Here, the metabolic activity is higher. And so now we've opened up the capillary and we've perfused it with blood. The capillaries are actually too small to allow the passage of white blood cells, and so they're going to go through the metarteriole on their way through to the venules. And then the venule is also part of this microcirculation. And so from there, we move from the capillary into the venule. And again, the venules are companion vessels to arterioles. And the post-capillary venule is actually leaky, and this is where those white blood cells can move across the wall and get out into the connective tissue that might be infected. And again, you know that eosinophils will get out here, neutrophils get out here and become phagocytic, monocytes move out here and turn into macrophages. And then we move into the veins, which are known as capacitance vessels. They're known as capacitance vessels because they're very distensible. They can open up and hold a large volume of blood. And in fact, they become reservoirs for blood. The truth is that at rest, you don't really need the entire 5 liters of blood that you have, or however much you might happen to have. The other thing that's important to remember, as we've already mentioned, the blood pressure here is actually too low to overcome gravity, and so how do we deal with that situation? And again, as we've said, veins have valves to help prevent the backflow of blood, especially when you're standing up for long periods of time. And here again, we can see another adaptation to help overcome the low blood pressure that we have here. The venules actually have a bigger lumen. And so, again, you might not understand this, but we'll talk about it later. The bigger lumen decreases resistance to blood flow and helps to ensure that blood will continue to move even with the much lower blood pressure that we have there. I'd like you to pause the video and look at the pie chart and see what you can conclude from looking at it. And keep in mind that this is at rest. And so what you should have noticed is that clearly at rest, the majority of the blood is actually over here on the venous side, and it's actually about 2/3. So approximately 66% of the blood is over there on the venous side. And here you can see this in this graph as well. And this provides us with a reserve of blood. And during exercise, you're going to constrict the veins and squeeze out much of the blood that's there and move it into the active circulation. Here you can see an artery and a vein. And look at the endothelium of the artery compared to the vein. Here you can see that the endothelium appears to be a little bit crinkly in the artery, whereas in the endothelium it's nice and smooth. And again, the reason is because we push a large volume of blood into the arteries and they're going to stretch out. That's going to stretch this out and take the slack out of it as we do that. The veins are responsible for returning blood to the heart, and that blood that comes back to the heart is referred to as venous return. And the heart is responsible for most of the work to get the blood all the way back to the right atrium or to the left atrium, but it gets some help, especially during exercise. This is the blood that's returning to the heart through the vena cava. And when you exercise, one of the things that happens is your muscles are contracting fairly forcefully and they're squeezing those veins. And as we squeeze the veins, it pushes the blood that's in there out of them. And again, since we have valves down here, the only direction that the blood can go is back towards the heart. This is what's referred to as the muscle pump. And it's fairly straightforward and fairly easy to understand. Something else that helps is the respiratory pump. And you need to remember the volume-pressure relationship. And again, you remember that in the volume-pressure relationship, as the volume of something increases without changing the amount of fluid that's in there, the pressure will decrease. On the other hand, as the volume decreases without changing the amount of fluid in there, the pressure will increase. And that's what's happening every time you inhale and exhale. And so when you inhale, the diaphragm contracts and moves downwards. That's increasing the volume up here in the thoracic cavity, which decreases pressure. At the same time, it's decreasing the volume in the abdominal cavity, which increases the pressure. That squeezes on the inferior vena cava. We reduce pressure on the superior vena cava, and so a little bit more blood comes up through here. And then again, lastly, one of the things that happens is when you're exercising, sympathetic nervous system is highly active, and it's going to cause vasoconstriction. So you do have some smooth muscle in the veins, not a whole lot. And as that smooth muscle contracts and the vein diameter decreases, it's going to squeeze out some blood. And again, because of the valves that we have in the veins, that blood always has to move back towards the heart. And so these three things are very important in helping the heart to do the work of getting blood all the way back, especially to the right atrium, but also to the left atrium. And so that brings us to the end of our discussion of the vascular system.